I'm Dr. Joseph Lim. On behalf of CME Outfitters, I'm pleased to welcome you today for the CMEO briefcase. It's entitled Critical Steps for Long-Term Management of HBV Focus on Monitoring and HBV Reactivation. Today's program is supported by an educational grant from Gilead Sciences. I'm a professor of medicine and director of clinical hepatology at the Yale School of Medicine in the section of digestive diseases and Yale Liver Center in New Haven, Connecticut. Our learning objective today is to routinely monitor patients with hepatitis B every 6 months for disease progression, liver cancer, and hepatitis B reactivation in patients undergoing immunosuppressive drug therapy. So let's go ahead and meet our patient. His name is Thomas, who is a 31-year-old male who's meeting with his oncologist. He is someone who has immigrated from Nigeria as a child and has been diagnosed with anti-CD20 positive B-cell non-Hodgkin's lymphoma. His oncologist plans to initiate rituximab therapy. Now let's go to a video that shares his story.
Hello, Thomas. How are you today?
Hey, Dr. Franklin. I've been a bit fatigued lately. I don't know if it's because of the cancer or anxiety about starting treatment, but I haven't slept too much lately.
I can certainly understand that. Diagnosis of B-cell non-Hodgkin's lymphoma can be scary. The fatigue is probably a little bit of both, the cancer and the anxiety. Your B-cell non-Hodgkin's lymphoma is CD20 positive. I'd like to begin treatment with a drug called rituximab. Now, one of the side effects of rituximab is that if you have a history of hepatitis B, it may make your hepatitis B flare. Do you have any history of hepatitis B?
No, I've never had hepatitis.
Let's go to audience response question number 1. What will your next step be in alignment with ASCO recommendations? So for this question, I like to highlight that in patients who are going through cancer chemotherapy, and particularly those that are B-cell depleting therapies, such as rituximab or anti-CD20, it is considered a standard recommendation to undergo routine hepatitis B screening. In response A, I think ordering routine pre-chemotherapy blood tests, of course, is reasonable and appropriate, and scheduling the patient for chemotherapy may be appropriate depending on the HBV status. And therefore, the most correct answer for this question would be to proceed with routine HBV screening. In this next slide, we review the geographic distribution of patients with chronic HBV infection. It is estimated that approximately 290 million persons worldwide have chronic infection. The predominant distribution of chronic HBV are particularly in the Asian and African continents. And in these continents, the estimated prevalence of chronic HBV exceeds 8%. And in addition, you'll see here on this global map that additional regions, particularly in the Middle East, Eastern Europe, Russia, and portions of North and South America have prevalence estimated at greater than 2%, which is defined as intermediate risk. Why is this important? Well, first, the CDC recommends that individuals who are from intermediate or high-risk countries in terms of country of origin should undergo screening for hepatitis B. And in addition, it is estimated that up to 70% of individuals with chronic HBV in the United States are from countries of high endemicity. And it's in this context that our patient, who is an immigrant from Nigeria, would be in the group that is deemed to be at high risk for HBV, and independent of chemotherapy would represent a candidate for HBV screening. Now, our primary topic of discussion today is the concept of HBV reactivation. This is an uncommon but underappreciated complication of cancer chemotherapy. It has been remarkable that the advances in immunotherapy and biologic therapy have led to revolutionary changes in our ability to treat a number of solid and hematologic malignancies, autoimmune disorders such as rheumatoid arthritis, psoriasis, and IBD, as well as novel therapies in the context of transplantation, both stem cell and solid organ. However, rarely these can be associated with reactivation of the hepatitis B virus, which in turn can be associated with substantial morbidity and mortality. And therefore, it is important that this is something that is carefully considered in advance of initiation of immunosuppressive drug therapy. In addition, it is rare but possible that individuals undergoing HCV DAA treatment may also experience hepatitis B reactivation. The implications of HPV reactivation are not limited to the liver sequelae, but also discontinuation and or delay in cancer chemotherapy, which can lead to poorer oncologic outcomes. What exactly is hepatitis B reactivation? In concept, the idea is that it is one of two scenarios. First are in individuals who have never had active hepatitis B infection, but have had exposure to hepatitis B. These individuals, although they don't have active viremia or active infection, in the context of immunosuppression, the hepatitis B may reactivate due to a loss of immunologic control, in which they become viremic again with active chronic HBV infection. The second scenario are individuals who already have HBV with active viremia, who in the context of immune suppression may have significant activation of the virus to much higher levels with active hepatitis. So let's go through the specific definitions and scenarios. In the first context, this is a patient who is surface antigen positive with positive HBV DNA, active chronic HBV. And the reactivation is defined as an increase in HBV DNA of at least 1 log magnitude compared to baseline. In the second scenario, this is someone who is surface antigen positive, HBV DNA negative, where they go from negative DNA to positive DNA, a pretty clear scenario. And then third scenario is someone who is surface antigen negative, but positive core antibody. In other words, there's someone who does not have active infection, but had exposure to HBV in the past with resolution. And in these cases, if they have experienced reactivation, they may have surface antigen conversion from negative to positive and the reappearance of positive HBV DNA. Collectively, these three scenarios define HBV reactivation. Now, how often are patients undergoing cancer chemotherapy being underscreened for HBV? There are a number of studies that have tried to address this question. On this slide, we present one example of a large study from a major academic cancer center in whom 12,000 patients receiving parenteral chemotherapy were evaluated for the presence or absence of HPV screening prior to initiation of chemotherapy. In this cohort, approximately 17% were screened for either surface antigen or core antibody prior to chemotherapy, and only 15% had undergone both surface antigen and core antibody testing. This is quite sobering and highlights that there's underscreening for HPV in this patient population. That's been demonstrated in multiple cohorts at major cancer centers across the US. And it is of note that it does appear that screening appears to occur less commonly in community oncology clinics relative to teaching hospitals and provide impetus for improvement in quality improvement strategies. Immunotherapy and hepatitis B reactivation has long been described, particularly with regards to cancer chemotherapy and a number of biologic agents. With the rise of immune checkpoint inhibitors and other biologic strategies that are of unique immune strategies, it's important to better study the unique association with hepatitis reactivation. Are there differences between different classes of immunotherapies with regards to HPV reactivation risk? And furthermore, does this have implications for those who are surface antigen positive versus core antibody positive alone? And does this imply that there are differences in how we approach the screening for hepatitis B and its treatment? Let's return to our patient here.
Okay, Thomas, I have some tests I want to run, but even though you do not believe you've ever had hepatitis B, I'm going to add screening lab tests to your blood work.
I don't think I understand. Wouldn't I know if I had hepatitis B?
Hepatitis B doesn't always show up as an acute illness. It may be dormant in your system. There are parts of the world where hepatitis B is more prevalent, and your country, Nigeria, is one of those countries in Africa. It's highly infectious and can be transmitted horizontally, which means you may have contracted it from a household contact.
Oh, I didn't know that. I was pretty young when I immigrated, but I don't think I recall any of my immediate or extended family having hepatitis B, but who knows?
Okay, let me note the exact test I need for the chart, and you can head on over to the lab.
Okay, Dr. Franklin, thanks.
This audience response question, number 2. What serology tests should Dr. Franklin order for Thomas to confirm his hepatitis B status? For this question, I have to admit this is a somewhat of a trick question because there are actually two responses which may be correct. In the next slide, we'll be discussing some of the guideline recommendations for screening of hepatitis B in individuals undergoing immunosuppressive drug therapy. So the initial response that I would view as correct is number B. And so this is the patients who undergo screening based on core antibody prior to or rituximab therapy, or C, surface antigen, core antibody, and surface antibody prior to or at the beginning of rituximab therapy. And so in a sense, the most correct answer is C, because this implies that you have screened both for the surface antigen and the core antibody at minimum, and in addition, the surface antibody. As a reminder, the surface antigen is the test to look for active HBV infection. Core antibody looks at any prior exposure, whether it's current or in the past, and the surface antibody indicates whether someone has developed immunity. Either natural immunity from prior exposure and infection has resolved, or vaccine-induced immunity after completion of a three-step vaccination series. Let's go through the guidelines. What are the screening tests that are recommended by our societies? As you'll see here, that the number of societies, including the AASLD, the AGA, and the ASCO, the American Society of Clinical Oncology, recommend a two-test strategy at minimum, including the hepatitis B surface antigen and the anti-core antibody. In contrast, the CDC and the European Liver Society, EASL, recommend a three-test strategy, including hepatitis B surface antigen, core antibody, and surface antibody. And in this context, I think that clinicians like you and me should carefully consider for our patient which of these strategies may be most appropriate for your patient. Now, my own personal take on this is that it is intuitive that we should pursue all three tests because it provides complete information about a patient's hepatitis B status. Are they infected? Have they ever been exposed? And third, are they immune? And provides opportunity for those who are not previously immunized, naturally or vaccine, to pursue an immunization series. Let's return to our case. So we get the results back for Thomas, our patient, and we confirm that he is surface antigen positive, core antibody positive, which confirms the presence of chronic HBV infection. His HBV DNA is relatively low, around 850 IUs per ml, and his ALT is at borderline normal levels at 29 units per liter. Remember, our AASLD guidelines suggest that standardized normal are 35 in men and 25 in women. And so on this basis, this person is someone who already is designated as having active HBV infection. Further laboratory testing confirms that he is negative for co-infections with hepatitis C, hepatitis delta, and HIV. Fiber scanning elastography is performed and confirms the presence of stage 2 liver fibrosis. An ultrasound is performed, which reveals normal liver architecture, no morphologic evidence of liver cirrhosis, and no evidence of a focal liver mass or liver cancer.
Hi, Thomas. I got your blood work back. And in addition to the other tests that we routinely order prior to starting chemotherapy, I ordered tests to determine if you have ever been exposed to hepatitis B. And in fact, you have been.
Really? I still don't understand how I could have something as serious as hepatitis B and not even know it.
It's actually not that uncommon to be exposed to hepatitis B and not be aware of it. Many people are chronically infected with hepatitis B, but we need to be aware because immunosuppression with chemotherapy can cause Hep B to flare. So it needs to be factored into your treatment decisions.
Does this mean I'll have to delay treatment for my cancer?
So let's proceed to the next audience response question. Based on these laboratory results, what would your next step be that you would recommend? Okay, so response A, delay rituximab treatment until you have a consult with hepatology. That is not necessarily inappropriate, particularly if the treating clinician feels uncomfortable in helping make this decision regarding the hepatitis B status and the potential need for antiviral prophylaxis. However, in general, the same principle applies that we would like to minimize delay of oncologic treatment, recognizing that may be directly linked to oncologic outcomes, and so it may not be the preferred response. Response B, continue with rituximab and monitor labs, and so the idea here is that you recognize the patient has hepatitis B, but you don't worry about it. The cancer chemotherapy is priority. Don't worry about the hepatitis B. You can worry about it later. That's the perspective. That is an inappropriate response because we recognize that patients with rituximab therapy may be at high risk for hepatitis B reactivation, particularly if they already have active HBV. And therefore, the risk of hepatitis and potential liver failure may be really spark a need to consider antiviral prophylaxis. Response C, initiate prophylaxis with antiviral therapy for hepatitis B, is the most correct answer. And we'll review the guidelines that inform which patients and at which time and with which antiviral is recommended for the treatment or prophylaxis of HBV reactivation. Response D, cancel rituximab therapy due to risk of liver complications is inappropriate. The idea here is that we don't want to delay or obviate the need for cancer chemotherapy, but to make sure that it can be done in a safe manner with concurrent antiviral prophylaxis. In this next slide, we review some general principles and algorithm for how we risk stratify patients for hepatitis B reactivation. So the principle is that in all patients undergoing immunosuppressive drug therapy, that screening for HPV is strongly recommended. In individuals who are surface antigen positive, in whom you have confirmation of active infection, you want to distinguish whether they have high, moderate/intermediate, or low risk for activation. If they're surface antigen negative, core antibody positive, you'll want to again determine whether or not this person has high, intermediate, or low risk for reactivation. In individuals who are deemed to be high or moderate risk, HPV reactivation prophylaxis is suggested with the initiation of an oral antiviral. In individuals who are at low risk for reactivation, that usual medical care can be pursued with watchful waiting, with monitoring for the low likelihood of reactivation. Now, in general, this concept of high, moderate, or low risk is determined in part based on the HPV status, of course, but also on the basis of the choice of immunologic therapy, recognizing there are, in fact, differences between biologic or chemotherapy classes in regards to this risk. High is typically defined as greater than 10% risk, moderate or intermediate risk, 1 to 10%, and low risk, less than 1%. I strongly advise that you look at the guidelines from the AGA, AASLD, and ASCO that help to define the specific classes that fall within these risk categories. And finally, the last group are those who are surface antigen negative, core antibody negative. These are patients who don't have active HBV and have never been exposed to hepatitis B and therefore are not at risk for reactivation. And those patients can proceed with usual medical care with cancer chemotherapy. Let's proceed to our next audience response question. What antiviral prophylaxis treatment would you choose for this patient? Okay, so let's go through our answers here. The best answer would be D, entecavir or tenofovir, which are oral nucleoside-nucleotide analogs that have very high potency and a very high barrier to resistance that have good tolerability. Interferon is generally not recommended because of its immunosuppressive effects that are concurrent with that of the primary cancer chemotherapy and should be avoided for HBV prophylaxis. Lamivudine is a historical oral nucleoside analog that is not necessarily incorrect, but is no longer preferred because of high rates of resistance. In response C, sofosbuvir is an outstanding antiviral for hepatitis C, but not for hepatitis B. So entecavir tenofovir is formally recommended by all liver societies in regards to antiviral prophylaxis. Let's next proceed with a review of our current guidelines by our major societies from the AASLD, AGA, and the European Liver Society. And I like to divide this in two major groups. First are those with chronic hepatitis B, abbreviated CHB, and the second group, those with resolved HBV, who are surface antigen negative, but hepatitis B core antibody positive. So for those who with chronic HBV infection, all three societies, AASLD, AGA, and EASL, generally recommend antiviral prophylaxis for most patients, in particular for those with high or intermediate risk of reactivation based on the chemotherapy. Now, the choice of antiviral is based on high potency, high barrier to resistance drugs, including entecavir or tenofovir in either formulation of TDF or TAF. The duration of therapy is dependent upon which immunosuppressive drug therapy the patient is being given. In general, the AASLD and AGA recommend 6 to 12 months of oral antiviral prophylaxis after completion of immunosuppressive drug therapy, but with an exception that if someone is on rituximab or other anti-CD20 therapy, that 12 months is strongly preferred. The European Liver Society, in contrast, recommends that 12 months is preferable for all patients, and again, for those with rituximab or other anti-CD20 therapy, up to 18 months should be employed. And therefore, there is some nuance, both not only in the selection of antiviral therapy, but in the duration of therapy beyond completion of immunosuppressive drug therapy. Generally 6 to 12 months, and those going to anti-CD20, 12 to 18 months. The second group that I'd like to discuss are those with core antibody positivity alone, those with resolved HBV infection. In these patients, the risk of reactivation generally is slightly lower than those patients with active HBV, which is quite intuitive. And therefore, there is much more attention to the stratification between high, intermediate, or low risk. For the AASLD, they recommend that if someone is undergoing high-risk immunosuppressive drug therapy, such as rituximab or stem cell transplantation, antiviral prophylaxis is strongly recommended. In addition, AASLD recommends monitoring of other patients in whom you are not pursuing antiviral prophylaxis, with monitoring every 1 to 3 months with serum ALT, HBV DNA, and the hepatitis B surface antigen. The AGA further stratifies patients on high, intermediate, or low risk in those with core antibody positivity alone. High risk includes those with CD20 therapy, such as rituximab. Moderate risk includes those with TNF alpha, cytokine inhibitors, integrin inhibitors, TKIs, or low-dose corticosteroids, recognizing that some patients with high-dose steroids long-term may actually fall within the high-risk group. In these cases where there is an intermediate risk, it is important that shared decision-making be pursued with your patient so they have a clear understanding about what the risk is for them and make a careful, patient-driven decision as to whether they'd like to proceed with antiviral prophylaxis if they want to minimize risk, or whether they prefer watchful monitoring without antiviral prophylaxis, accepting potential risk of reactivation. And then finally, the European Liver Society, for those with resolved infection, again recommends high-risk patients undergo immunosuppressive drug therapy with prophylaxis, but for those with low or intermediate risk, that consideration may be given for watchful waiting with on-demand treatment with monitoring every 1 to 3 months. So let's return to our patient. Now, we have highlighted here that Thomas, as someone who has surface antigen positive virus with DNA that otherwise would not meet criteria for antiviral therapy on the basis of hepatitis B infection alone, he would meet criteria for antiviral prophylaxis because he's undergoing a high-risk treatment with rituximab anti-CD20 therapy. But the issue is not limited to the hepatitis B reactivation alone, but also about management of his chronic disease. We want to remind you that patients with chronic HBV are at high risk for liver cancer lifelong. HBV is the leading cause of liver cancer worldwide. In fact, hepatitis B is the #2 carcinogen in the world after tobacco because of the association between this virus and liver cancer. Unlike other liver diseases, HBV is unique because it can cause liver cancer at any point in the natural history of the disease. It does not require cirrhosis first, as typically is observed for hepatitis C. We see that there's a disproportionate burden of HBV-related liver cancer in Africa and East Asia, in which representing about 60% of all HBV-related liver cancers worldwide. So some of the predictors of liver cancer risk in patients with hepatitis B include the following. hepatitis B e antigen positive, high HBV DNA, and genotype C type of chronic HBV. In addition, we will highlight further that family history of liver cancer and those with cirrhosis also bear a higher risk of liver cancer. Now, past or resolved HBV may lead to resolved infection, but does not entirely eliminate the risk of complications of HBV, such as liver cancer, cirrhosis, or liver death, particularly if they have co-infections or if they have other liver diseases. Although HBV can occur at any point in the natural history of a chronic HBV infection, it still remains the truth that the predominance of liver cancer occurs in those with cirrhosis, which remains the leading risk factor for HCC in patients with chronic HBV. I'd like to discuss with you briefly the concept of the HBV natural history. Now, we recognize that there are two distinct branch points in the natural history of chronic infection of those who have e antigen positive infection and e antigen negative infection. Within the first two phases, e antigen positive, there's the immunotolerant phase, E positive, high DNA, normal ALT, and then the second phase, e antigen positive, high DNA, high ALT. And the distinction is that individuals in that second phase, what we call immunoactive phase, that there's active liver injury as a consequence of the immune reaction to the hepatitis B virus. And therefore, this represents a key phase for antiviral therapy. Whether this patient is treated or not, there are spontaneous mutations that occur in the viral population, including the pre-core and basal core primary mutations that lead to a seroconversion of the e antigen positive from positive to negative. And this, what we call the inactive carrier phase of chronic HBV infection. Unfortunately, this has often been called incorrectly the benign carrier phase. Unfortunately, there's nothing benign about this phase because by definition, these patients have already gone through the first two phases of infection. And during that second phase of immunoactive disease, they may have already sustained substantial liver injury and liver fibrosis during this phase, and may even have advanced fibrosis at this time. And therefore, these patients with inactive carrier phase, they need to be monitored carefully for the possibility of either spontaneous or immune-mediated reactivation. So in our patient today, Thomas likely is within this inactive carrier phase, likely e antigen negative, with low DNA and normal ALT. Although he normally would not require antiviral therapy, at minimum, he should be monitored for reactivation, either spontaneous or immune-mediated. Because he is undergoing anti-CD20 therapy with rituximab, he represents the classic context in which immunotherapy may lead to reactivation and should require antiviral prophylaxis. Let's review the patients who are the highest risk for liver cancer. Based on AASLD guidelines, these are the patients who are not only high risk, but should be prioritized for cancer screening and surveillance. Among patients with hepatitis B, all Asian males age 40 or older, Asian females age 50 or older, any patient with hepatitis B with a family history of liver cancer, African or North American Blacks with hepatitis B age 20 or older, and anyone with hepatitis B and liver cirrhosis. Collectively, these four groups are the highest risk individuals for liver cancer and should be prioritized for HCC surveillance imaging, which we'll review on the next slide. Now, in addition to those specific to hepatitis B, I want to take the opportunity to review the other high-risk groups for liver cancer, including those with hepatitis C cirrhosis, stage 4 primary biliary cholangitis, also known as PBC, genetic hemochromatosis and cirrhosis, alpha-1 antitrypsin deficiency and cirrhosis, and other forms of cirrhosis, regardless of etiology. Now, how good are we as clinicians in screening for liver cancer? On this slide, we have at least one data set which underscores the fact that we aren't actually very good and that there's much work to be done. On the left, we have data looking at quote-unquote high-risk individuals for liver cancer based on AASLD criteria. Now, what we see here is that at the 6-month, 9-month, and 12-month time points, we see only a small subset of patients actually undergoing HCC surveillance. And in fact, within a year of observation, up to 30% of individuals, even among high-risk groups, fail to have any HCC surveillance imaging performed. On the right, we look at a screening on the basis of liver disease severity with a major stratification point of those with HBV cirrhosis, the highest risk group for liver cancer. Even in this high risk group based on liver disease severity, we see major deficits regards to HCC surveillance imaging. And again, the major point being is that there's much work to be done by us as clinicians to ensure that appropriately high-risk individuals are screened for liver cancer in those with HBV. So let's look at the monitoring guidelines. Who should we screen, and how should we screen, and how often should we screen? And so what we see here is the AASLD recommends that individuals who are deemed to be at risk for liver cancer undergo liver ultrasound with or without serum alpha-fetoprotein, AFP, every 6 months. We recognize there's some nuance to this recommendation. First, it is the imaging study. The ultrasound is the primary screening tool, not the serum AFP. Serum AFP is a good tumor marker, but an imperfect one. It is estimated that about 1 out of 3 patients with liver cancer may have a normal serum AFP, and therefore does not exclude liver cancer in isolation. And therefore, if it's used, it should be used in conjunction with a liver ultrasound. The other caveat is that we recognize there are some patients in whom liver ultrasound may be inadequate, either based on body morphology or other radiographic noise that limits the ability of ultrasound to detect liver tumors. In these patients, CT scan or MRI as cross-sectional imaging may be needed to obtain adequate imaging to perform HCC surveillance. One common strategy, although not endorsed by guidelines in some individuals, particularly those who have concomitant fatty liver, is to alternate ultrasound with a cross-sectional imaging study every 6 or 12 months accordingly. And this is something that should be discussed with your patient on a case-by-case basis. Now, we also recognize that the AASLD is mindful that in patients who have poor functional status with poor overall prognosis, specifically those with decompensated cirrhosis who are not transplant candidates, it is reasonable to discontinue surveillance in these patients if it is not thought that the results of that ultrasound would alter your management. For the majority of patients with this exception, HCC surveillance is strongly recommended. At this time, I'd like to review our SMART goals: specific, measurable, attainable, relevant, and timely. First, be aware that hepatitis B reactivation may occur in patients undergoing immunosuppressive drug therapy and is often underappreciated until late stage. And therefore, all patients undergoing immunosuppressive drug therapy should be screened for hepatitis B. How should we screen? A minimum of surface antigen and coronary antibody, and ideally with a third test, the surface antibody, to assess for immune status. Third, in patients who meet the criteria based on AASLD, AGA, and ASCO guidelines, particularly those with high or intermediate risk for reactivation, you should initiate antiviral prophylaxis with either entecavir or tenofovir. The duration of therapy should typically be 6 to 12 months and 12 to 18 months in individuals undergoing anti-CD20 therapy, such as rituximab. In patients with chronic HBV, don't forget that HCC surveillance is strongly recommended to reduce the risk of liver cancer in these patients. And this is defined as ultrasound with or without serum AFP every 6 months in a long-term basis. I'd like to thank you for your participation in today's program and remind you that the CMEO briefcase is first one of a series of 3 programs that is available for your viewing pleasure. I encourage you to go to our Liver Hub website, cmeoutfitters.com/liver-hub. And with this, I'd like to thank you again for your participation in today's program and look forward to seeing you next time here at CME Outfitters. Thank you again for your attention.